Can you tell me about your current experience with orthopedic nursing?
I have been working as an orthopedic nurse for the past 3 years on a 30-bed elective orthopedic ward in a busy teaching hospital. My experience covers the full patient journey from preoperative assessment to postoperative recovery and discharge planning. I care for patients undergoing a wide range of procedures including total knee and hip replacements, spinal fusions, and arthroscopic surgeries. I am highly experienced in monitoring neurovascular status, managing complex pain relief such as patient-controlled analgesia, and working closely with physiotherapists and occupational therapists to ensure patients mobilize safely and achieve their functional goals before discharge. In addition to elective surgery, my ward also receives trauma patients, so I have managed external fixators, patients in traction, and postoperative care following emergency procedures like intramedullary nailing for fractures. I have developed strong skills in wound care, pin site management, and early recognition of complications such as compartment syndrome or deep vein thrombosis. Over the past year, I have also taken on the role of preceptor for newly qualified nurses. This has helped me strengthen my communication and leadership skills while ensuring that safe, person-centered care remains at the heart of everything we do. I genuinely enjoy orthopedics because I see patients make visible progress every day, which is very rewarding.
What does a typical handover look like for you on an orthopedic ward?
On my orthopedic ward, a typical handover follows the SBAR structure, which keeps communication clear and patient safety at the forefront. I prefer to give handovers at the bedside whenever possible because this allows the incoming nurse to see the patient, check wounds and drains together, and involve the patient in the conversation. I start with the patient's name, age, and what surgery they had or what injury they are being treated for. Then I move to the situation, explaining any overnight events like uncontrolled pain, fever, or a fall. For background, I give a brief summary of their medical history and any relevant details like mobility status before admission. My assessment covers the key areas for orthopedic patients: pain levels and analgesia given, wound condition and any drainage, neurovascular observations, and how well they have mobilized with physiotherapy. I also mention their fluid balance, bowel function, and any specific equipment they are using such as braces, slings, or continuous passive motion machines. Finally, I state my recommendation, which often includes pending blood results, planned physiotherapy goals, or discharge arrangements. The whole handover takes about 20 to 30 minutes for a full assignment of 8 to 10 patients. I find that bedside handover reduces errors, builds trust with patients, and ensures we start the shift with a shared understanding of each patient's needs.
How do you prioritize your care when you have a full assignment of postoperative patients?
When I have a full assignment of postoperative patients, I prioritize using a combination of clinical urgency, time since surgery, and individual patient needs. I begin my shift by reviewing each patient's handover notes and identifying those who are most clinically vulnerable. Patients who are freshly postoperative, usually within the first 6 to 12 hours, always come first because they require frequent neurovascular observations, pain assessment, and monitoring for early complications like bleeding or compartment syndrome. I also prioritize patients with unstable vital signs, uncontrolled pain, or those requiring intravenous medications such as antibiotics or patient-controlled analgesia. Once I have assessed and stabilized these patients, I move on to those who are further along in their recovery but still need assistance with mobilization, wound care, or preparation for discharge. I find that grouping tasks efficiently helps me manage my time well. For example, I cluster neurovascular checks and pain assessments together during my first round so I am not constantly going back and forth. I also communicate closely with the healthcare assistant to ensure that basic needs like hygiene, toileting, and nutrition are met while I focus on clinical assessments. If a patient is scheduled for physiotherapy or has a planned discharge, I make sure those tasks are completed early so that therapy sessions are not delayed and discharge happens before the evening. I constantly reevaluate my priorities throughout the shift because a patient's condition can change quickly. If I ever feel overwhelmed, I escalate to my clinical nurse manager so that we can redistribute tasks and maintain safe care for everyone.
What are the key neurovascular observations you perform immediately post-TKR?
Immediately following a total knee replacement, I perform neurovascular observations every 15 to 30 minutes for the first 2 hours, then hourly until the patient is stable. I focus on the 5 Ps, which are pain, pulse, pallor, paresthesia, and paralysis. I start by assessing capillary refill in the toes of the operated leg, ensuring it returns within 2 seconds. I then palpate the dorsalis pedis and posterior tibial pulses, comparing them to the non-operated leg to establish a baseline. I ask the patient to wiggle their toes and dorsiflex and plantarflex their ankle to assess motor function and check for any signs of foot drop. I pay close attention to sensation by gently touching different areas of the foot and lower leg, asking the patient to tell me if they feel numbness, tingling, or burning. Pain assessment is also critical, but I differentiate between expected surgical pain and neurovascular pain. I look for any calf swelling or tenderness that could indicate deep vein thrombosis. I also inspect the wound dressing to ensure it is not too tight, as excessive compression can compromise circulation. I document all findings clearly and escalate immediately if I notice any deviation from baseline, such as absent pulses, coolness, severe unrelieved pain, or new numbness. I remember one patient whose pain became suddenly severe and unresponsive to analgesia, and my prompt escalation led to the diagnosis of compartment syndrome, which required urgent surgical intervention. That experience reinforced for me how vital these frequent, systematic checks truly are.
How do you manage a patient's pain to allow them to participate in physiotherapy on the day of surgery?
I believe that effective pain management is the foundation of successful early mobilization after surgery. I start by reviewing the patient's prescribed analgesic regimen during the morning handover and ensuring that any PRN medications are given at the right time before physiotherapy arrives. I coordinate closely with the physiotherapist so that we schedule sessions when the patient's pain relief is at its peak effectiveness. For example, if a patient has regular paracetamol and ibuprofen, I make sure those are given at least 30 minutes before the planned session. If they have stronger opioids available on a PRN basis, I assess whether they need an additional dose beforehand. I also use non-pharmacological methods to support pain relief. I ensure the patient's surgical limb is well elevated and that ice packs are applied to reduce swelling and discomfort. I check that the patient has used their patient-controlled analgesia effectively if they have one, and I encourage them to press the button before they start moving rather than waiting until the pain becomes severe. I remember caring for a gentleman who had a total knee replacement and was very anxious about moving because of his previous experience with surgery. I sat with him, explained that we would go slowly, and gave him his PRN morphine 20 minutes before physiotherapy arrived. I also stayed beside him throughout the session, offering encouragement and adjusting his position when he felt discomfort. He managed to stand and take a few steps, which gave him the confidence he needed for the rest of his recovery. I always communicate with the patient about their pain goals and reassure them that we have a plan to keep them comfortable while still achieving the mobility milestones that are so important for preventing complications.
What specific complications are you vigilant for following a knee replacement?
Following a knee replacement, I am vigilant for several key complications, and I assess them systematically throughout my shift. The first complication I watch for is venous thromboembolism. I monitor for unilateral calf swelling, warmth, redness, and pain, and I ensure the patient is compliant with their prescribed anticoagulation and mechanical compression devices. I also educate patients about the signs of pulmonary embolism, such as sudden breathlessness or chest pain, so they can alert me immediately. Infection is another critical complication I look for. I inspect the surgical wound at least twice daily for any signs of increased redness, swelling, warmth, or purulent discharge. I also monitor the patient's temperature and white blood cell count closely. I remember one patient who developed a low-grade fever on the second day after surgery, and upon closer inspection of the wound, I noticed a small area of erythema spreading beyond the dressing edge. I escalated this to the surgical team, and we started antibiotics early, which prevented the infection from progressing to a deeper joint infection. I am also very vigilant for neurovascular compromise. I perform regular checks of the pulses, capillary refill, sensation, and motor function in the affected limb. Swelling after a knee replacement can sometimes compress the popliteal vessels or nerves, so I ensure the limb is elevated and that the dressing is not too tight. I also monitor for excessive bleeding or oozing from the wound, as this can lead to hematoma formation, which increases the risk of infection and can delay mobilization. Finally, I watch for complications related to immobility, including pressure ulcers and constipation. I encourage early mobilization with physiotherapy and ensure the patient is repositioned regularly when in bed. By staying vigilant across all these areas, I can identify problems early and intervene before they become serious.
How does postoperative positioning differ for a shoulder replacement compared to a lower limb replacement?
Postoperative positioning for a shoulder replacement is quite different from lower limb replacement because the priority shifts from weight bearing to protecting the integrity of the repaired joint and surrounding soft tissues. For a lower limb replacement like a total knee or hip replacement, the focus is on maintaining correct alignment while allowing early weight bearing and mobilization. The patient is usually positioned supine with the limb elevated to control swelling, and they are encouraged to move freely within safe limits. For a shoulder replacement, however, positioning is much more restrictive in the early postoperative period. I always ensure the patient is positioned with the affected arm supported in an abduction pillow or sling. This device holds the arm slightly away from the body and maintains the shoulder in a stable position, protecting the new joint and preventing excessive movement that could compromise the surgical repair. When the patient is lying in bed, I position them in a semi-reclined or upright position rather than flat, as this reduces stress on the shoulder joint and promotes comfort. I also educate the patient and the healthcare team about specific precautions. For a shoulder replacement, the patient must avoid certain movements such as lifting the arm forward, reaching behind the back, or rotating the arm outward until the surgeon gives clearance. When turning the patient or helping them move up in bed, I always support the affected arm and never pull on it. I recall caring for a gentleman who had a total shoulder replacement, and during the first night he kept trying to use his operated arm to reposition himself in bed. I adjusted his bed to a comfortable reclined position, placed pillows strategically to support his arm, and reminded him frequently to let us help him move. This careful positioning not only protected his new joint but also significantly reduced his pain and allowed him to rest comfortably. In contrast, with lower limb replacements, I am focused on early mobility and preventing complications like deep vein thrombosis through movement rather than restriction.
What patient education is crucial regarding sling use and abduction pillows?
Patient education regarding sling and abduction pillow use is absolutely crucial because proper compliance directly affects the success of the surgery and prevents complications. I always start by explaining the purpose behind these devices. I tell the patient that the sling and abduction pillow are not just for comfort but are there to protect the surgical repair by keeping the shoulder in a stable position while the tissues heal. I explain that if they move the arm incorrectly, they could strain the repair, cause pain, or even compromise the surgical outcome. I demonstrate exactly how to put on and remove the sling correctly. I show them how to support the elbow when taking the arm out for hygiene or dressing changes and how to reposition the arm back safely without letting it hang unsupported. I emphasize that the sling should be worn at all times except when they are doing prescribed exercises or performing gentle hygiene. I also teach them about the abduction pillow if one is prescribed. I explain that this pillow keeps the arms slightly away from the body to protect the rotator cuff or the new joint surfaces, and they must not remove it independently. I use a teach-back method to confirm their understanding. I ask them to show me how they would put the sling on and explain to me when they can take it off. I remember one elderly lady who was very independent and kept taking her sling off because she found it uncomfortable. I sat with her and her daughter and explained that wearing the sling was like wearing a cast for a broken bone. We found a softer undershirt to reduce skin irritation, and her daughter helped remind her to keep the sling on. I also educate patients about skin care, showing them how to check for any redness or irritation under the straps or around the abduction pillow. I reinforce that they should call us immediately if they feel numbness, tingling, or increased pain. Finally, I provide written instructions and ensure their family members understand the importance of compliance so they can offer support at home.
What additional considerations do you take into account when caring for a patient undergoing a revision joint replacement compared to a primary one?
Caring for a patient undergoing a revision joint replacement requires me to be more vigilant and thoughtful compared to a primary replacement. I recognize that these patients often have more complex medical histories, longer surgical times, and greater physical and emotional fatigue from previous surgeries. I always start by thoroughly reviewing their surgical history to understand what led to the revision, whether it was infection, implant loosening, or mechanical failure, because this guides my monitoring priorities. Infection risk is a major consideration. Revision surgeries often involve more extensive dissection and longer operating times, so I am extra vigilant about wound observation, temperature monitoring, and aseptic technique during dressing changes. If the revision is due to a previous infection, I pay close attention to microbiology results and ensure antibiotics are administered exactly on time. I recall caring for a gentleman who was having a revision hip replacement due to a previous prosthetic joint infection. He was anxious and worried that the same thing would happen again. I took time to listen to his fears, explained the infection prevention measures we were taking, and involved him in his care by teaching him what signs to watch for after surgery. Pain management also requires special consideration. These patients often have higher pain levels due to scar tissue and more extensive surgery. I assess their pain frequently and collaborate with the anesthetist and surgical team to ensure they have an effective multimodal analgesia plan. I also consider their mobility differently because revision patients may have had previous restrictions or reduced function. I work closely with physiotherapy to set realistic goals that account for their baseline mobility and the complexity of their surgery. Blood loss is another consideration, as revision surgeries can be associated with greater blood loss. I monitor hemoglobin levels closely and watch for signs of hypovolemia. I also consider the patient's psychological needs, as many revision patients feel discouraged that their first replacement did not last. I provide reassurance, celebrate small milestones with them, and connect them with peer support if available. Overall, I approach revision patients with extra patience, thorough assessment, and a focus on both physical and emotional recovery.
What is your protocol for monitoring a patient in an external fixator?
My protocol for monitoring a patient in an external fixator focuses on 4 main areas: pin site care, neurovascular assessment, pain management, and patient education. I begin each shift by inspecting every pin site carefully. I look for any signs of infection such as redness, swelling, warmth, purulent discharge, or loosening of the pins. I follow our hospital's strict aseptic protocol for pin site care, which involves cleaning each site with normal saline and using sterile gauze to gently remove any crusting. I never use hydrogen peroxide or alcohol unless specifically prescribed, as these can damage healthy tissue. I document the condition of each pin site and report any concerns to the surgical team immediately. I also perform thorough neurovascular assessments at least every 4 hours, or more frequently if the patient is freshly post-operative. I check capillary refill, pulses, sensation, and motor function in the affected limb. External fixators can sometimes compress nerves or blood vessels, especially if swelling increases, so I compare the affected limb to the unaffected one and note any changes. I recall one patient who developed sudden numbness and tingling in his toes after a lower limb external fixator was applied. I escalated this immediately, and the surgical team adjusted the frame, which relieved the pressure and restored normal sensation. Pain management is another key part of my monitoring. External fixators can be uncomfortable, and pin sites can cause significant pain. I assess pain regularly and ensure the patient has adequate analgesia, especially before physiotherapy or any repositioning. I also check that the fixator frame is stable and that all screws and clamps are secure without being too tight against the skin. Finally, I focus heavily on patient education. I teach patients and their families how to recognize signs of infection and how to perform pin site care if they will be doing it at home. I explain the importance of keeping the frame clean and dry and avoiding trauma to the area. I also provide emotional support, as external fixators can be intimidating and can affect body image and mobility. I encourage patients to express their concerns and involve them in decisions about their care to help them feel more in control during what can be a long and challenging recovery.
How do you perform a peripheral neurovascular assessment on a limb that has just undergone IM nailing?
When performing a peripheral neurovascular assessment on a limb that has just undergone intramedullary nailing, I approach it systematically and with a gentle touch, as the patient is often in significant pain and the limb is swollen and tender. I start by introducing myself and explaining exactly what I am going to do so the patient knows what to expect and feels reassured. I compare the operated limb to the unaffected limb throughout the assessment to establish a clear baseline. I begin with circulation. I inspect the color of the toes or fingers, looking for any pallor, cyanosis, or unusual redness. I then check capillary refill by gently pressing on the nail bed of the big toe or thumb, counting how many seconds it takes for color to return. I expect refill within 2 seconds. Next I palpate the pulses. For a lower limb IM nailing, I assess the dorsalis pedis and posterior tibial pulses. For an upper limb, I assess the radial and ulnar pulses. I grade the pulses as present, diminished, or absent, and I always compare to the unaffected side. I then move to sensation. I ask the patient to close their eyes and tell me where they feel my touch. I lightly touch different areas of the foot or hand, including between the toes or fingers, and ask if sensation feels normal, decreased, or altered. I also ask specifically about any numbness, tingling, or burning sensations. For motor function, I ask the patient to perform simple movements. For a lower limb, I ask them to wiggle their toes, dorsiflex their ankle, and plantarflex their ankle. I observe the strength and range of motion. For an upper limb, I ask them to wiggle their fingers and make a fist. I also assess for foot drop or wrist drop, which can indicate nerve injury. Pain assessment is integrated throughout. I ask the patient to describe their pain and whether it is the expected surgical pain or something different, such as severe, unrelenting, or disproportionate to the injury. I remember one patient who had an IM nailing of the tibia and kept reporting that his pain was worsening despite regular analgesia. During my assessment, I noticed his toes were becoming pale and his capillary refill was sluggish. I also found that he was unable to dorsiflex his foot as well as he could an hour earlier. I escalated these findings immediately, and the surgical team diagnosed early compartment syndrome. He was taken to theater for fasciotomy, and because we acted quickly, he avoided permanent damage. That experience reinforced for me how critical thorough, repeated neurovascular assessments are in the postoperative period. I document all my findings clearly and ensure the next nurse understands the baseline so that any changes are caught early.
A patient with a long leg cast complains of severe pain unrelieved by medication. What is your immediate response?
When a patient with a long leg cast complains of severe pain that is not relieved by medication, I treat this as a potential orthopedic emergency and act immediately. My first response is to stop whatever I am doing and go to the patient to assess them face to face. I do not dismiss their pain or assume it is just normal postoperative discomfort, because severe unrelieved pain can be the first sign of compartment syndrome or other serious complications. I begin by asking the patient to describe their pain in detail. I want to know when it started, exactly where it is located, and how it feels. I ask if the pain is worse than expected or if it feels different from the pain they had before. I then perform a thorough neurovascular assessment on the affected limb. I check the color of the toes, looking for pallor or dusky discoloration. I assess capillary refill, ensuring it returns within 2 seconds. I palpate for pulses, comparing them to the unaffected foot. I gently test sensation by touching different areas of the foot and asking if they feel numbness, tingling, or burning. I also ask them to wiggle their toes and assess their motor function. I look for any swelling that may be causing the cast to become tight, and I check if the cast edges are digging into the skin. I recall a specific situation where a young man had a long leg cast following a tibial fracture. He was calling out that his pain was a 10 out of 10 and that morphine was not helping. When I assessed him, I noticed his toes were pale and he said his foot felt like it was burning. He could barely wiggle his toes. I immediately escalated to the orthopedic registrar and explained my findings. I also elevated the limb to chest level and removed any blankets that were putting pressure on the cast while waiting for the medical team to arrive. The registrar arrived within minutes and decided to perform a bivalving of the cast to relieve pressure. Within moments of the cast being split, the patient's pain improved significantly and the color in his toes returned to normal. The cast had become too tight due to swelling, and my quick response prevented any further complications. I always document my assessment findings, the actions I took, and the outcome clearly so that the whole team is informed.
Describe how you log roll a patient post-spinal surgery.
Log rolling a patient post-spinal surgery is a skill I perform with great care because maintaining spinal alignment is essential to protect the surgical site and prevent complications. I never attempt to log roll a patient alone. I always ensure I have at least 2 or 3 trained staff members assisting me, and I explain the process to the patient beforehand so they understand what is going to happen and can cooperate with us. Before we begin, I check that all tubes, drains, and monitoring lines are free and will not be pulled or tangled during the movement. I also ensure the patient's bed is at a comfortable working height to protect my own back. I position one staff member at the patient's shoulders, one at the hips, and myself usually at the legs or head depending on the team. I give clear instructions so that we all move together on the count of 3. The patient lies flat on their back with their arms crossed over their chest. I instruct them to keep their head and neck in line with their spine and not to twist. On the count of 3, we gently roll the patient as one unit, keeping the head, shoulders, spine, hips, and legs in a straight line. We do not allow any twisting or bending of the spine during the movement. Once the patient is on their side, I place pillows behind their back to support them in this position and a pillow between their knees to maintain proper alignment and prevent pressure on bony prominences. I remember caring for a gentleman who had undergone a lumbar spinal fusion. He needed to be turned for a pressure area assessment and for personal hygiene. I gathered 3 staff members, and we planned the turn carefully. I explained to the patient that we would keep him straight like a log and that he should relax and let us do the work. We moved him smoothly and slowly. After we positioned him on his side with pillows for support, he told me he felt safe and that his back was not painful during the turn. That feedback reassured me that we had performed the skill correctly. I also used this opportunity to inspect the surgical wound, check drain output, and assess the patient's skin for any signs of pressure damage. Throughout the process, I continue to monitor the patient's pain level and stop immediately if they report any discomfort.
What specific neurological observations do you monitor post-operatively?
Following spinal surgery, I monitor specific neurological observations to detect any early signs of spinal cord compromise or nerve root injury. I perform these assessments hourly for the first several hours post-operatively, then gradually space them out as the patient stabilizes. I always compare my findings to the patient's baseline and document them clearly. I start with motor function in the lower limbs. I ask the patient to dorsiflex and plantarflex both ankles, pushing against my hand to assess strength. I also ask them to extend their knees and lift their legs off the bed. I look for any asymmetry, weakness, or inability to perform these movements. I then assess sensation by lightly touching different dermatomes on both legs and feet, asking the patient to tell me where they feel the touch. I pay special attention to any numbness, tingling, or areas where sensation is reduced compared to the unaffected side. I also assess the patient's ability to feel light touch around the perineal and sacral areas. This is important because reduced sensation in this region, known as saddle anesthesia, can indicate cauda equina syndrome. I ask the patient if they have any new difficulty with bladder or bowel function. I monitor their ability to pass urine and watch for any signs of urinary retention or incontinence. I recall one patient who had undergone a lumbar discectomy. During my neurological assessment on the evening of surgery, I noticed that she was unable to dorsiflex her left foot as strongly as she could earlier in the day. She also mentioned that she felt some numbness on the outer aspect of her left leg. I repeated the assessment to confirm my findings and then immediately escalated to the orthopedic registrar. I provided clear information about the changes I had observed. The registrar reviewed the patient and ordered imaging. It turned out that a small hematoma was compressing a nerve root, and the patient required a return to theater for evacuation. Because I detected these changes early and acted quickly, we prevented permanent nerve damage. That experience reinforced for me how vital these focused neurological observations are in the postoperative period. I always ensure I am thorough and never hesitate to escalate when something does not seem right.
A patient post-spinal fusion reports they haven't passed urine 6 hours post-op. What do you do?
When a patient post-spinal fusion reports they have not passed urine 6 hours after surgery, I treat this as a priority because urinary retention can lead to bladder distension, discomfort, and increased risk of urinary tract infection. It can also be a sign of neurological compromise, particularly cauda equina syndrome, which requires urgent intervention. My first step is to assess the patient fully. I ask them how they are feeling and whether they feel any urge to urinate or any discomfort in their lower abdomen. I gently palpate the suprapubic area to check for bladder distension. If the bladder feels full and the patient is uncomfortable, I know retention is likely. I also perform a focused neurological assessment, checking sensation around the perineal and sacral areas, lower limb motor function, and asking about any new numbness or tingling. This helps me rule out cauda equina syndrome, which is a surgical emergency. I recall a specific situation where a patient who had a lumbar spinal fusion was 6 hours post-operative and had not passed urine. He was becoming increasingly agitated and complained of lower abdominal pain. When I palpated his bladder, I could feel a distinct fullness. I performed a bladder scan, which confirmed over 500 milliliters of urine retained. I knew we needed to act. I first attempted non-invasive measures. I helped the patient into a comfortable position, ensuring his spine was well supported with pillows. I provided privacy by closing the curtains and running the tap to help stimulate the urge. I encouraged him to try to void naturally. Unfortunately, these measures were not successful. I then escalated to the surgical team and explained my assessment findings, including the bladder scan result. The registrar reviewed the patient and prescribed an in-out catheterization. I explained the procedure to the patient, obtained his consent, and performed the catheterization using a septic technique. I drained 800 milliliters of urine, which provided him with immediate relief. Afterwards, I documented the event clearly, including the volume drained, the patient's response, and the neurological assessment I had performed. I continued to monitor his bladder function closely for the remainder of my shift. I also ensured that this information was communicated during handover so the next nurse could continue to monitor for any recurrence of retention or any signs of neurological deterioration. I always remember that in spinal patients, urinary retention can be a red flag, so I never dismiss it or simply assume it is a routine side effect of anesthesia without thorough assessment.